All right, good morning and welcome to AT Talks. AT Talks is a collaboration between the Michigan Assistive Technology Loan Fund and Disability Rights Michigan. And I'm Tracy Strading, the director of the Michigan Assistive Technology Loan Fund. First, just a few housekeeping items. Please type your questions into the QA or chat boxes or raise your hand as an accommodation on the screen, and I'll be able to unmute you so that you can ask your question at that point out loud if you wish. And we do welcome your questions throughout the presentation. I'm very happy to introduce our speaker today, Dr. Kelli Bogue. Dr. Bogue was born and raised in Jackson County and graduated from Napoleon High School. After learning about speech-language pathology and eventually audiology, she earned her undergraduate degree in communication arts and sciences from Michigan State University and her Doctor of Audiology degree from Ohio University. Her diverse experience also includes a residency at the Dayton VA Medical Center, along with services at various clinics and a tenure with a major hearing aid manufacturer. Along with her husband, Tyler, Dr. Bogue opened a community hearing center to ensure her patients receive a treatment plan that's tailored to their individual needs, based on best practices and delivered in a warm, inviting environment. So I'm thrilled today to have Dr. Bogue present on patient-centered hearing device treatment. Thank you, Dr. Bogue. We're ready for you.
Thank you. All right. Are you able to see everything okay? And hear me okay?
Yes, everything's good to go.
All right. Well, thank you, Tracy, for giving me the opportunity to speak today. I have been practicing audiology for the past 15 years. And in that time, I have been privileged to work with a lot of people who have hearing loss, as well as individuals who help to provide access for hearing care. When I think about why I wanted to be an audiologist and why people ask me that, one of the things that I tell them is that I love audiology because it is a combination of art and science. Each person is unique, regardless of how similar their hearing loss might look. When we keep that in mind, when we're working with individuals with hearing loss, that is so essential for designing and helping to collaborate on a treatment plan. Today, we're going to talk about patient-centered hearing care. And as Tracy mentioned, I do invite you to ask questions as we go along. My goal is to be a resource and to complement your existing knowledge of hearing care. When we think about hearing loss, it's such a prevalent condition. It's one of the most, if not the actually most common neurological condition in the world. Over 360 million people, kids, adults across the world have hearing loss. And when we think about hearing loss, we know that the brain is where we're thinking about the processing for sound. The auditory cortex is where those primary structures for processing are located. But over time, our knowledge has evolved to know that the entire brain is actually involved when it comes to listening and processing. And when somebody has hearing loss, it makes it harder for them to be able to recognize sounds. And because they are working with incomplete sound information, they have to work harder because they're simultaneously trying to fill in the gaps. They're trying to make guesses. And we probably have all been in a situation before where we've misheard somebody and maybe responded incorrectly, or we've had somebody else do the same to us. And sometimes it's funny, but for a lot of people that have hearing loss, it becomes a source of frustration, as well as for their family and their friends. And we know that when you are working harder to account for missing auditory information, it is allowing for less mental bandwidth for other activities, and it does result in actually feeling more tired. Auditory fatigue is a real element for people who are trying to deal with hearing loss on a daily basis. We also know that hearing loss affects more than just our ears. When we're thinking about treating hearing loss, a big motivator for treating in a person-centered approach should be considering all of the conditions that are comorbid or co-occurring with hearing loss. A lot of these if they're not addressed, can have a cascading effect. If somebody has hearing loss that's going untreated and they're missing out on conversations or feeling burdensome from having to ask from repetition, that may cause them to withdraw from different social situations. And that withdrawal can definitely lead to feeling isolated. It might lead to them feeling depressed. So there's a lot of factors that we want to consider with regard to the whole element of hearing care. That is something that we're thinking about with regard to addressing treatment plans with a person-centered approach. So it's important that we always recognize that patients are individuals who need to be active participants in their care. We need to make sure that we're addressing their motivation and their readiness, making sure that we're paying attention to their individual wants, their needs, their values, knowing that people's interaction with their hearing loss can change throughout their lifetime. Their cultural values make a big difference. There's a lot of elements that we need to be addressing when it comes to ensuring that we are providing care that is focused on the goals of each individual patient. We're thinking about wanting to make sure that we are addressing care as seamlessly as possible. A lot of times when people come in to see me and we're doing their intake, they will be surprised about the depth of questions that we ask, because we're going deep to make sure that we're looking at a lot of different aspects of their healthcare that maybe are not monitored as well as they should be, but maybe we can help to bring those things to the forefront of their physician's mind or some other provider's mind. And so when we can ask things like, about medications that they're taking or other conditions, going back to the comorbid conditions, diabetes, for example, we know that folks that have diabetes are more likely to have problems with their hearing loss. And if that diabetes is not well managed, the changes with their insulin can directly impact their hearing loss. So if we are getting feedback from our patients about these kind of elements of their healthcare, and we can help to encourage them to share that with their GP, or share that, when we send back notes or report to them, we can try to ensure that we're helping to manage all these different aspects of their hearing care in a way that's going to be most beneficial to them. We want to think about when folks are coming in to be helped with their hearing, if that's, across kind of the span of different options that we have, which we'll get into. We want to think about the different elements that patients are having to put into this process. There is a large amount of labor from a patient's perspective that we don't necessarily always remember. When we think about the emotional labor that a patient has to put into treating a hearing loss, their feelings, their attitudes in seeking help, different communication problems that are associated with that, the cognitive labor that goes into it, making sure that they are able to achieve success with different rehabilitation options and goals, and the physical labor of it. We don't necessarily always think about the fact that there is going to be some type of physical and of course, monetary effort that goes into being able to treat their hearing loss. And if we remember these elements that patients are contending with when they're coming in to receive treatment, I think it goes a long way toward making sure that we are keeping empathy also at the center of how we are providing care. When we are thinking about the diagnostic approach, so when we're having somebody come in for a hearing evaluation, there are several pieces that we want to consider. But the first thing that we want to think about is the actual ear itself and kind of how that works, so that you know what we're thinking about when we get into sort of the testing portion of things. So the ear is divided into three main sections. We have the outer ear, we have the middle ear, and we have the inner ear. And then we have the information, the auditory nerve that's taking that information up to the brain. And so we have the processing that's happening in the brain. You can have a hearing loss as a result of something happening in any of these portions of that auditory pathway. You may also have a hearing loss that is the result of multiple areas of that auditory pathway being affected. And hearing loss can happen across the lifespan. It may be something that happens in utero. It may be present during something that happens when a child is, being born. For most folks, it is something that happens later on in life. And again, a combination of things. One of the things that I will routinely talk about with patients is hearing loss in and of itself is not just a function of like getting older. A lot of people think I've gotten older and that's the cause of my hearing loss. It's not so much that it's just a function of age. It's a function of all of the things that we are exposed to and interact with throughout our life. Hearing loss is cumulative. So if I talk to somebody about noise exposure, for instance, and they tell me, well, I used to hunt, but I haven't hunted in 20 years. That is something that's still relevant because those exposures haven't gone away. So when we think about maybe a child who had hearing loss because of fluid in their ears, if they had chronic ear infections, that can change the structures of the middle ear space. That could contribute to maybe a little bit of a low frequency loss that has kind of persisted into adulthood. And then maybe they've had a job where they were exposed to loud noise, or maybe they served in the military, or they had noise exposure recreationally. That's another element. Maybe as they have progressed further into life, they have developed various health conditions like diabetes, for instance. That's further changing their hearing. All of these components of things that we interact with are, like I said, cumulative to what is causing somebody to have a hearing loss. And so that's why having a very person-focused approach when we are analyzing and treating makes a big difference, because everybody is unique in how their history, how their experiences are going to shape their hearing loss and how they interact with it. When we think about the types of hearing loss, there are some main types that we're considering. So along the auditory pathway, if somebody has a blockage, essentially, so if there is something that is preventing sound from literally getting into the inner ear, maybe that is a wax blockage, maybe it's fluid in the middle ear space, maybe it's a hole in the eardrum. Those are examples of what we would call a conductive loss. Generally, conductive losses are things that have a medical resolution. They can generally be fixed. And when that's the case, if the inner ear is still working, there's not damage to it, there's not damage to the auditory nerve or something that's happening in the brain, usually those folks are able to see resolution to where their hearing is back to what we call within normal limits. If the damage to the hearing system has occurred in the inner ear or along the auditory nerve, that's something that we would call a sensory neural hearing loss. Those types of losses are generally permanent. Sometimes they are resulting from a condition like an infection in the inner ear that might be resolvable if it's addressed soon enough. I routinely joke to people that are not currently having this problem, but that I sort of am on a soapbox to educate people about the potential of a sudden sensory neural hearing loss. It's not that it's a super common thing, although I do see a fair amount of them. But if somebody ever had a sudden change in their hearing and they did not address it right away, and by right away, I mean ideally in the first week to 2 weeks, but not longer than a month after that drop was perceived, if it's the result of an infection in the inner ear, you likely will not see any kind of reversal back to your baseline. So getting treatment for something like that is very serious. We hope that, if you had a sudden change, maybe it is something that's just like an earwax issue, or maybe it's your sinuses or allergy issues. But those are things that we don't want to sit on, because if you miss that window, it is devastating to know that you maybe could have had a reversal of that loss, but you've not had the opportunity to potentially treat that. If somebody has a hearing loss that is a combination of a conductive component, so something happening in that outer or middle ear space, as well as something going on in the inner ear. So maybe it's somebody who has had damage because of noise exposure, and maybe they also have an ear infection on top of it, or they've had significant ear infections to the extent that it's not something that's going to be resolved medically. They may have more of a combination of the two. We call that a mixed hearing loss. And then there are additional losses that can occur as a central type of hearing loss. So something that's going on in the nerve or something that's happening in the processing in the brain. And those folks may not have a measurable hearing loss, but they still seem to have a lot of difficulty, not seem to, they have a lot of difficulty with understanding speech, with processing speech, integrating information, particularly in challenging, noisy background type situations. So there's a lot of different elements to hearing loss and types of hearing loss that we need to make sure that we're aware of and take into consideration when we're providing hearing care. When somebody is coming in for a hearing evaluation, there are multiple elements of the process. The initial intake, as I mentioned, for us is pretty in-depth. So we want to make sure that we're getting a detailed history, not just an audiological history, but also the patient's medical history. We're thinking about the range of various health conditions that somebody may have, medications that they're taking. That's another piece that I try to provide a lot of education on. And that is the fact that there are hundreds of medications that are ototoxic and vestibulotoxic. So it means that they are potentially going to cause hearing loss, tinnitus, balance problems, or a combination of them. And a lot of those medications are things that are very commonly prescribed. For instance, certain types of blood pressure medications or water pills, which a lot of times go hand in hand. Higher dosages of NSAIDs. And a lot of those things we also see increasing in more common prescription for folks as we are further along in the lifespan. So being aware of those things can make a big difference. And knowing that even though there are a lot of drugs that might have that as a potential side effect, it doesn't mean that somebody is going to. But if somebody were prescribed a type of blood pressure medication, an ACE inhibitor, for instance, that was causing them to have tinnitus, and maybe that's a new prescription for them. If we are aware of that and we find out like, oh, hey, well, this tinnitus started around the same time that I started taking this medication, let's let your GP know. Let's either you let them know, we'll let them know. We'll, both approach that and see, is there something else that we might be able to have this patient switch to, a different medication, change in dosage, to see if we could resolve that new symptom that was not previously there. We also want to make sure that we are addressing patients' goals, their motivation. I always start every appointment by asking patients, what is your goal or what outcome would you like to achieve today? And even with continued follow-up visits, I try to ask patients, what is top of mind for you? Because while there are things that I want to make sure that we address to ensure that I'm providing good quality care, I want to make sure that first and foremost, we're addressing the things that brought you in today. And I'm not assigning you a goal just based on what I see with regard to your hearing loss, because as I mentioned, everybody interacts with their hearing loss differently. And we can have two patients who have essentially the same loss on paper, but their perception of that hearing loss and how it affects them can be totally different. And what they're looking for in terms of help with the hearing loss can be totally different. So knowing patients' goals, their motivation, where are they at in the process for wanting to take steps to treat a hearing loss? And or is it just, I want a baseline. I just want to know where I'm at. I want to start monitoring things. I don't want to be made to feel bad that I have a loss and I'm not doing anything about it yet, but I just want to be informed about what's happening. And then maybe I can start to consider, kind of open my mind to potential options that could help me with whatever my goals are to be successful in my communication endeavors. And in doing that, there are a lot of resources available to us. So there are various types of surveys that we can provide patients with to be able to assess their goals, to be able to assess how they're feeling with their severity of their loss, how it's impacting their quality of life. And then continuing those things with something that might be more significant even beyond, is that something where we are concerned about depression? Are we concerned about, other health aspects that co-occur with hearing loss? If somebody has tinnitus, for instance, there's a huge range of the way that people are impacted by their tinnitus. For some people, that tinnitus, just as a side note, is that ringing, buzzing, chirping, humming, there's various types of descriptors for it, but it's a sound that's generated generally in the brain. There are some exceptions to that, but generally it's generated in the brain. It's a symptom of an underlying cause, which is typically hearing loss. But there are folks who have tinnitus, and by and large, they're not bothered by it. Maybe it is something that they have heard constantly for the past 20 years, but they've habituated to it. But there are other folks who they are very bothered by it, and it affects their concentration, and it affects their ability to sleep, and they're thinking about it, and it's creating a lot of anguish for them, and it's really affecting their quality of life and their mental well-being. So providing patients with various types of questioning or surveys to be able to pull out more information so that we know what their feelings are on these things that might be affecting them is really, really essential. And using those again later on to see how our treatment or how recommendations have been able to change that. Are they having improvements or not? Is there something else that we need to recommend? Are there other professionals that we need to collaborate with to help improve their quality of care if it's not being met with where they're at that point? So when we are thinking about hearing testing, when we're getting into the actual test itself, there are several elements that a patient might encounter. First and foremost, otoscopy. So looking in somebody's ears. And my my husband can attest to my somewhat frustration when I go to like our pediatrician's office or other doctor's offices, and like I'll watch another provider look in our kids' ears, and they're frequently really, really far back. They're like 6, 8 inches back from their otoscope. And I'll say to him later on, I'm like, they can't see anything in that kid's ear. If you are that far back, you're not actually being able to make a good assessment. So just at a basic level, let's look in there and see what's going on. And that tells us right off the bat, right? Are things nice and clear? Is there potentially some earwax in there? Does it look like there's an infection? Is there a hole in the eardrum? That's just prepping us for what to expect as we continue along with our evaluation. We will do a test of middle ear function next. And so that can be a combination actually of different tests. Tympanometry is the main one that we're thinking about. So that is, if you've never had this test done before, but there's a probe that we put up against the opening of the patient's ear canal, and we're taking a measurement to see how sound is moving across the eardrum and the bones in the middle ear space. It kind of feels like, I tell people, if you're driving in a hilly area. So it has kind of a little bit of a pressure change that you are feeling in your ear. There are other types of tests that are done with that same piece of equipment, acoustic reflexes, decay. These are, again, things to help us diagnose what might be going on in that middle ear space, potentially other types of things like a retrocochlear pathology, so like a tumor that we're trying to determine if that might be going on. There's a variety of disorders that we are able to get a heads up on just from this initial evaluation. Sometimes we have to do other types of tests like otoacoustic emissions or an ABR, an auditory brainstem response test. Those are more common ones. There's certainly other elements of electroacoustic testing that might be above and beyond that, but generally those are things that we see in a more common way. But those are measurements that we can utilize for patients who may not be able to respond to behavioral measures. So it gives us an idea, like with the otoacoustic emissions, are we able to rule out the presence of, anything greater than basically like a mild hearing loss? So again, it gives us some important diagnostic information for somebody who has an asymmetric hearing loss, and depending on the severity of that hearing loss, if we are concerned about the potential for a retrocochlear pathology, so a tumor, a benign tumor called an acoustic neuroma that might be on the auditory nerve, an ABR test is a way that we can get an idea of how sound is moving along that pathway, that auditory pathway, and see, based on the responses that we get back, we're looking at waveforms that indicate, are we receiving sound along that pathway up to the brain, or is it somehow delayed? And where are the delays at? We look at what we call the morphology or the shape of these waveforms, and being able to analyze that can tell us whether or not people maybe need to have further testing. So jumping to something like an MRI, for instance, or a CT. Ideally, if we can try to prevent people from having to go through something that's more intensive. And for a lot of people, they don't like being in really small spaces that are required for something like an MRI or CT. So if we can, again, consider patients and put them first, these kind of evaluations can help give us more information to make sure that we're providing the best quality of care and not requiring that they have unnecessary tests done that might be otherwise able to be analyzed. When we are looking in the ear, not a lot of people have seen in the actual ear. So this is a screenshot of looking down in somebody's ear canal, just if you want to see what something, that looks nice and healthy is. We're looking at the eardrum straight ahead. If you are looking through the eardrum, so the clear circle at the end there, you can see the bones in the middle ear space. You can see elements of the ossicular chain. The piece that to me kind of looks like a music note, sort of like at about 1 o'clock and then coming down toward the center. We're seeing that first middle ear bone there, and we're seeing off to the side at about 4 o'clock, that shiny area. It's called the cone of light. So just healthy anatomical markers. If we were looking at an ear canal that was blocked with wax, the image on the left shows you an example of what that looks like. You cannot see the eardrum in this person. So that would be like somebody kind of having an earplug in. And depending on how much wax in there, significantly so. On the right side, an example of a hole that's a pretty large perforation that's in there. But these images are things that we would look for when we were first looking in somebody's ears, and they tell us a lot of stuff right off the bat about what we can expect with regard to the diagnostic evaluation. When we are done analyzing the outer ear and the middle ear, that's when we would transition into the sound booth. And when we get into the sound booth, we are doing a combination of things. At a more basic level, we're thinking about our audiometry portion and we're thinking about our speech portion. Audiometry is what you traditionally probably think of with a hearing test. So it's hearing tones and then responding back either with, the push of a button or raising your hand or providing a verbal response. Sometimes it involves somebody turning their head, especially for maybe younger children who are not able to do those behavioral measures. They may be, turning their head in response to a visual stimuli or another type of auditory stimuli in the booth. We're using those responses to give us an idea about the type of hearing loss that somebody has. So like I mentioned before, the sensory neural, the conductive, the mixed, central, and the extent of the hearing loss. And while the extent or the gates that we use to measure the various categories of hearing loss are certainly not an end-all be-all, they are important when it comes to knowing what a patient is likely to be able to hear or not hear, and using that information with programming if somebody does decide that they want to pursue help for hearing loss with hearing aids. The big piece that is really, really essential when it comes to looking at hearing loss and how it affects people on a daily basis is speech and noise testing. This is such an essential test, and we're seeing more providers integrate this. Unfortunately, not as many as I would like, but I think that is gradually improving. These tests are letting us see, how do you do in everyday life? One of the frustrations that a lot of patients have vocalized in the past with hearing testing, to me at least, is that it's not representative of real life. You're in a booth that is very, very quiet. You have no other sound or distractions. The sound is being presented to you at a level that is appropriate for your hearing loss, which is good, but you don't have all the elements of everyday life that make hearing much more challenging. So speech and noise testing provides a more realistic perspective on how somebody's hearing loss is impacting them. And people tell me that all the time. They're like, that's it, that test, that's exactly how I feel when I'm in a restaurant, when I'm watching television and my spouse talks to me, when my family is over, when I'm riding in the car, that's what I experience. And so I think it helps them to also feel seen, knowing that we are looking at that aspect of what does it look like in a more real life type of way. And we want to look at each ear independently, as well as how the ears are processing that information together. particularly if somebody is having difficulty as a result of maybe an asymmetric hearing loss. When we're thinking about treatment options for somebody who might be looking at a traditional hearing aid versus what we call a bicross or a cross setup, where maybe that ear that isn't hearing as well does not necessarily benefit from traditional amplification, meaning that the sound is directed down through the ear canal, middle ear space, following the normal auditory pathway. They may be somebody who is better suited to wearing a transmitter and having that sound wirelessly sent to the better ear. These elements give us a better idea of how that works for them and what's going to be the most helpful in helping them to attain their goals. When we are done with the evaluation, when we're done with the diagnostic portion, we want to go over these results. We want to give recommendations, and we want to do it using a variety of modalities. We want to make sure that we are using plain language. Audiology, like many fields, is a big fan of acronyms. We have a lot of terms that to us we maybe sometimes take for granted are not something that most people don't interact with. But explaining things in a way that is not super duper technical, unless somebody wants that, certainly, but something that makes sense to folks. What is this actually equating to in your life? What are you hearing? What are you missing? Makes a big difference in understanding really how much hearing loss somebody has. For a lot of people, hearing loss tends to creep up on us. It doesn't generally happen instantaneously. It's not usually an overnight situation. And because it happens more gradually, we don't always realize how much we're missing and how much it's really affecting us. But when we are using tools like this audiogram here, this is kind of showing us some of the sounds that people interact with or speech elements. It helps to graphically allow them to compare what they're hearing with how those sounds or what those sounds are in their environment. So if you've not seen an audiogram before, just to kind of give you a general overview, if you are looking at the vertical axis, so along the left side there, we're looking at loudness levels. If you start at the top of the chart and then you work your way down, you start at 0, or actually it's -10 would be the highest, and then go down to 120. Those are loudness levels. That's measured in decibels. And then along the horizontal axis or the x-axis, we're looking at frequencies. So frequencies are what we think of as pitch. On the left side, where it says 125 hertz, that would be a very low pitch sound. Think like lower than like a Barry White. And then bringing your way over toward the right side up to 8,000 hertz, that would be a really high pitch sound. So you can see on the chart that kind of helps you to see these bird sounds, like birds chirping or the sound of a dog barking, a lawnmower, giving you an idea of where those kind of relative loudness elements are, where those different types of sounds are. And in the center, the yellow portion, we affectionately refer to as the speech banana. So that is showing us the vowel and consonant sounds, and again, where they fall. And we overlay a patient's audiometric thresholds on this type of chart so that they have a real-time comparison with what they're thinking about in, all these different situations compared to their hearing loss. If we are completing this evaluation and we are discovering that there are elements that require further intervention. If we're thinking about somebody who had abnormal otoscopy, right? So we're looking in their ears and we see a hole in the eardrum that they are not otherwise familiar with. We see something that appears to be an infection. If we've noticed that there is potentially a disarticulation of the bones in the middle ear space, maybe there is a big asymmetric hearing loss. There are a lot of different things that are red flags for us that we want to make sure that we refer on for, because some of these do have medical intervention that a patient might want to pursue. Sometimes they don't want that, but I still always make sure that I let patients know all the things that are going on, because ultimately it is their choice. I've had folks before that have told me people have diminished their interest in pursuing treatment or pursuing testing based on their age, which is incredibly disheartening. But they might say, well, somebody didn't tell me about XYZ thing because, I'm 80 or I'm 90, whatever. They didn't think I would want to do it. But that's not your place as a provider. That is a patient's decision. If they don't want to pursue something, certainly that's their choice. But it's our job to make sure that they are informed, they know the potential complications and what might be attainable should they decide to go forward. Even if it's just, I want to do some fact finding so that I'm fully aware of what's going on with my body. I mentioned before that when we are doing testing, we are considering, patient motivation, patient goals. So when we're reviewing options and going over what might be options that the patient wants to consider, talking about them with their goals and, where they think they would like to go forward, we always want to utilize those objective measurements as well as subjective measurements to determine what kind of benefit they have received from their treatment plan. So when we think about hearing loss being treated with hearing aids, the way that we verify that hearing aids are doing what they are supposed to do and providing evidence-based care is by verifying with what's called real ear or speech mapping. This type of measurement is done when we're fitting a hearing aid, and we take probe microphones, we put them in the ear canals. We want to get them very close to the eardrum, and we're looking at the output of the hearing aid at different levels. We're looking at the way the hearing aid is functioning overall. We're taking into account the specific size and shape of a person's ear canal, because that's very different. When manufacturers create algorithms to program hearing aids, they're using a standardized ear canal, whether it's an adult or a child. People are frequently different from that standard. I've had very few people that are like an exact match from what the manufacturer offsets are. It's a good jumping off point, but we want to verify, because if you have a very large ear canal, if you have a really tiny one, a really curvy ear canal, those differences create a different resonance. And so what we'll see when we run a measurement, when we run real ear measurements, is that we may have somebody who is vastly under amplified at certain frequencies or vastly over amplified at certain frequencies. But if we're not taking into account their individual ear canal size and shape, in addition to their audiometric thresholds, as well as what we call the acoustic coupling, which means the piece that fits in the ear, whether it's the whole hearing aid itself or whether it's the end of a device that maybe is hooked to a behind the ear component, if we're not marrying those three factors together, we're not making sure that that patient is appropriately fit. We don't know for a fact the hearing aid is doing what it needs to be doing. Sometimes we still have to adjust off of that, and that's okay. Ultimately, I tell patients their success, their happiness with that sound quality is going to motivate further changes, but we want to make sure that that is a place that we start so that we know they're hearing what they should be hearing. And that's really, really huge for children. If kids are not hearing those sounds that they need to be hearing, and this is from, onset, right? So if somebody had a hearing loss at birth, if they're not hearing those sounds, there are so many things that makes much more difficult for them. Being able to acquire language is very challenging if you're not hearing the elements of speech. And if you're not acquiring language, it's much more difficult to read. And all these things have these really cascading effects that happen if we're not making sure that we're providing that sound quality that is appropriate for that patient. So that's really, really essential. I mentioned, utilizing those outcome measures. So we want to check back in and see, how has the patient's perceived benefit changed? How has their perception of the treatment plan that you came up with together meeting their goals? Do they feel like they're happy with how things are going? Are their communication needs being met? Maybe there's things that we need to revisit. Maybe there's things that we need to supplement. But if we're not checking back in, we don't know. It shouldn't be something where somebody just gets hearing aids and they leave, or gets, whatever device and they leave. We want to check back in so that we can make sure that we are continuing to touch base with them and how their needs are changing. One of the ways that has gotten a little bit easier for a lot of folks is the option to work with teleaudiology. So we are able to provide follow-up services for folks who have devices that can connect them. So, generally that's going to be a smartphone, a tablet, a computer, but we are able to have remote sessions. We're able to do that in obviously a safe HIPAA compliant way so that we can make sure that, you know, their information is staying protected. But we can also do adjustments where maybe we don't have to do, you know, a video appointment, but we can receive information from them. We can make a little change based on their request. We can send it to them, and then they can upload it to their devices through a free app on the phone. So there are a lot of things that we can do, again, to help make sure that we are focusing on that patient and making ease of care, you know, lessening the labor that we mentioned earlier, lessening that labor for them and in meaningful ways. When we're thinking about helping somebody with hearing loss, there are a lot of different options that exist. So traditionally, we think about hearing aids. Hearing aids are not the end all be all, and hearing aids generally are better off if they are combined with other options. Nowadays, every hearing aid pretty much is smart. You are hard pressed to find an analog hearing aid. I don't really know any manufacturers that make something like that. Sometimes you can modify settings to sort of make it work that way, but they're all pretty darn smart. And for most folks, that is a good thing. There are a lot of features that are standard in them that never used to be the case. So there's a lot of options technologically, and we'll unpack a few of these assistive devices that can be along with the hearing aids. So that might look like somebody who needs a remote microphone. So a device that a companion might wear and takes the sound of their voice and puts it wirelessly into the patient's hearing aids. It might be a TV streamer. I've yet to have a patient not love a TV streamer. TV is traditionally another environment that is really challenging for a lot of people for a variety of reasons. But a TV streamer is something that can hook up to a television and, again, takes that sound, puts it wirelessly into their hearing aids. That's a game changer for so many people. We know TVs fluctuate vastly, right? Sounds can fluctuate across different, you know, programs, across streaming platforms. The acoustic environment that somebody is listening in makes a huge difference. How far away from the television are they sitting? Is it a reverberant space that they're in? You know, is it a high ceiling? Is it a hard surface with an echo? What other kind of people are in this space too? You know, are there other folks, family members maybe that are in that space and they're talking or they're watching shows? Are they wanting the volume different from the person that has hearing loss? They're wanting it maybe at a different volume. Is it something where maybe they want to hear the television and the people around them would prefer to have it quiet? Maybe they're wanting to read or do some other activity. So devices like that, you can mute the television, you can hear it just in your hearing aids. Sometimes people don't necessarily need these things right off the bat or want them, but letting them know that they exist so that they are the ones that can make the decision for themselves is huge. When I first started practicing, I was working for an ENT over on the east side of Michigan. And I had a gentleman who'd been wearing for a really long time. One of my absolute favorite patients, just really super nice guy. And he never had been told about a remote for his hearing aids. And this was prior to hearing aids having any kind of Bluetooth technology where you could use a smartphone. But he'd never been told that. And he had pretty significant manual dexterity issues. He had neuropathy in his hands, you know, so many elements for him that made hearing aids really, really challenging. And when we talked about an option for him to have a remote control, like this light bulb was just like going off and he's like, this is the best thing ever. Why hasn't anybody ever told me about this? I've been wearing for such a long time and nobody has told me that my life could be so much easier with a remote control. Same thing for a TV device for him. And he was the person who was just going around telling everybody, you don't have to struggle. There are other things that you can use with your hearing aids to help you have an easier time. And it hurt my heart that nobody told him that. But that's where making sure that it's something where you're informing the patient and letting them be a part of the decision-making process. It makes such a big difference in their success and their trust in you as a provider. Sometimes we don't necessarily need to go the route of a hearing aid, or it's not something that a patient wants. You know, it may be something that they're not ready for, maybe something that, you know, they're not aware of, like options to help supplement maybe a budget that isn't there. And they might want something like a directed audio device. There are devices that allow them to have, again, TV being a big one, have the sound amplified for them personally without having to wear a hearing aid. Devices that might hook up to the TV, devices that might be around where maybe they sit and they're just kind of like amplifying that sound specifically to that particular area, where letting everybody else around them still maintain at a volume that's appropriate for them, letting them know that these exist. As well as, if somebody has a significant hearing loss, that they need to be evaluated for perhaps a cochlear implant, or maybe if they have a conductive hearing loss, that they would do better with a bone anchored hearing aid. That's another element, that giving people all of the options makes such a huge difference. I've had folks where they did not know that they were a candidate for a cochlear implant, or a sort of a bimodal device where it's partially cochlear implant, but part of the device is utilized like a hearing aid. We would talk about, hey, you might want to have an evaluation for this done, because you might have better outcomes. The outcomes for cochlear implants have improved drastically. And if you're not informing patients that that is something that they could benefit from, you're doing them a disservice. When we're thinking about treating hearing loss, another big element is thinking about aural rehabilitation. And my analogy for aural rehabilitation is that it is basically brain training. It's physical therapy for the brain. That helps a lot of people sort of think about how this works. We mentioned that when we're thinking about auditory processing, we're thinking about not just the auditory cortex, but the whole brain being involved. And when you are trying to utilize sound more efficiently, being able to help your brain process speech easier and background noise, to fill in contextual cues, to help with faster rates of speech. There are so many elements that, helping in a auditory training way, make such a big difference in patients' ability to understand and process. And these things can be done independent of hearing aids. If I have somebody that comes in who they're struggling with speech understanding, maybe they're not ready for hearing aids yet, I have a little packet that I give them where we talk about auditory training, different types of exercises. I've got things that they can do that are able to be utilized without any type of technology, and then things that they can do with, again, a phone, a tablet, computer, whatever, if they want more of a guided approach. But a lot of times people have never been told that these things exist, and they make such a huge difference. Even if they're ready for hearing aids, using those two things in tandem, giving your brain back the sound, but also training it to use that sound in a more efficient way, makes such a huge difference.
Dr. Bogue, can I interrupt you just for a question
yeah,
here?
I'm sorry.
All right, super. Let me just make it a little bigger for myself. We serve a large number, this is from Vicky, we serve a large number of individuals with hearing loss for vocational rehabilitation services. Some individuals have comorbid disabilities, and we may need to provide them with psychological testing. We see unfair results for the person's abilities, as the tests are not as valid if hearing loss impairs their ability to benefit. We seek communication, quote unquote, assessments and come up empty-handed with resources for this. Are you aware of any, so that we can accommodate someone's hearing loss if other diagnostic or aptitude testing is needed? ASL is not always warranted, so we would like to ensure fair and valid assessments of their abilities and limitations. I'm hoping you got more out of that than I did, since I don't know all the
I want to see if I can see it in a chat, because I'll be honest, I'm a pretty visual person.
Yeah, me too. Yeah, if you
but
want
it's easier for me if I can read it.
Sure, go ahead and jump in there and take a look, so that you can answer. It sounds like an important question.
It is. So when it sounds like you're asking, and you can correct me if I'm not clear on this, is there a provider who is doing psychological testing that is taking into account people who have hearing loss and modifying the way that they're providing their assessments to account for that? Is that
Vicki,
correct?
oh, good, go
Hi.
ahead.
Yes, I saw that you gave me the ability to unmute again. So thank you so much. Yes, we do a lot of the psychological batteries just to assess somebody's aptitude, academic abilities, especially if they're asking for, assistance with college training or figuring out a career pathway that can accommodate the hearing loss. And so it might just be way more than just us providing hearing aids, for the person to keep their job. They might be looking to advance a new career pathway. And we just see this happen oftentimes where those test results are just so skewed because the person wasn't able to verbally engage and understand speech and follow the directions the same way. If the hearing loss has impacted them over, a great number of years, or if the hearing loss is more sudden where they're still adjusting for that and still need to support their families, pay their mortgages and things, that we just see these unfair results and we just come up empty handed every time we look for accommodations that could be done about that person's really ability to communicate during those testing appointments, or if there is somebody that does really understand hearing loss really well that can perform the psychological testing itself.
So off the top of my head, I am not familiar with somebody who is providing psychological assessments that also has the background with, kind of in-depth hearing knowledge. I'm not saying it doesn't exist. I just personally am not aware of that person. I know that there are some different options out there to try and help with folks who do have hearing loss. I think of one that had come out quite a few years ago, looking at cognitive testing for people that have hearing loss, because like you said, a lot of times there's a bias and people who have hearing loss are potentially not being accurately diagnosed because it's not taken into consideration. So this was a new test that had come out that was looking at providing cognitive testing without having to be able to hear any of the questions. It did require that you were able to see, so potentially, could be a complication there. But that was something that was pretty huge in trying to lessen, the likelihood that somebody is maybe not receiving an accurate diagnosis because of that. But unfortunately, like specifically related to like psychological testing, I'm not aware of, any kind of modalities for presenting that are at least something that's widely accessible to try and minimize that. I think it's hugely important. And I don't know if it would be something that having other types of, I don't know, not an individual that might be able to accompany them, almost not so much like an interpreter exactly, but that's, helping to aid in providing answers for them. I know that's not necessarily something that's always an option, but I unfortunately don't have a good resource for this. I wish that I did.
We also had a comment from Nan who said this is a big issue, especially with dementia testing and older folks. She said if it is verbal and if you aren't hearing correctly, you're going to respond inappropriately. So yeah, I'm not sure what the answer is, but it's definitely obviously something that people are dealing with.
Yeah, that was exactly what we were saying with the cognitive testing. It's looking to see, and not so much just cognition, but specifically looking at dementia, and that test made a huge difference in giving an option for folks who do have hearing loss, as long as they're able to see. And the cool thing about that particular device is that it does, at the very beginning of it, go through basically a screening to make sure that, one, the patient is seeing appropriately so that we can rule out that as being potentially, complicating factor. It also looks at dexterity. So you're using your hand and you're turning a device. And if you are not able to meet the requirements of that screening element before the actual testing starts, it also looks at, at age and other various demographic factors. But if you don't meet those requirements, then it won't let the patient continue on for additional assessment because it knows that it's not going to be a fair assessment there. But that, I think, was a huge one. And we certainly have a need for more options of that nature expanding into other areas.
I mean, that person-centered process from just a long history working in community mental health, I would say, we would look to the people that know them best.
Right.
If the communication is an issue. So I think, I'm not sure in that space how that would work differently, but I think calling it patient-centered really means we're going to center that person and the people that love them and know them best.
Right. I agree. That's kind of what my thought was. If there was somebody that was able to accompany them to try and help supplement that, I think it would be hugely beneficial for them to be able to have that person as a resource. And like I said, I don't know that it's always an option, but I think it ideally should be because it would help to, improve fairness and accuracy when they're receiving those assessments.
So a couple more comments. Elliot says, would these tests allow for someone to use a smartphone? They could use a transcription app like Live Transcribe or Otter to turn verbal words into text. So maybe that's for the group in terms of the ideas of the psychological testing. And then Vicky says her response is, I appreciate your response and thoughts about this. Could you please share the name of the test that you heard of for cognitive testing for individuals with hearing loss? Thank you so much.
Yeah, and actually here, hold on just a second for me.
Well, sure. While you're looking for that, I'm going to let everyone know that if you came in late in this presentation or someone that you know might want to see the presentation, in about a week, it will appear on MI-UCP, MI-UCP YouTube channel. So our AT Talks are loaded there, and this presentation will be available there, well, in perpetuity, probably. So if you want to refer anyone to this amazing information that I learned so much today, I never thought about the idea that by deciding for yourself what your hearing loss is caused from, you could actually lose something down the line. I don't know why medically it never occurred to me that other things could be going on if a person had hearing loss. I'm just making an assumption about what something's caused by. I tend to sort of think, oh, I feel this way because of that. Oh, she's given her email. If we can't locate it today, we can send that to her later.
I was trying to find the link, and you know what? It's one of those things where, of course, I'm having a brain fart on it right now. And probably the second we're done, it'll pop back up. But yeah, I will note that, and then I can send that out. Cognitive View just came back. So,
oh, good.
Is the test.
Okay.
And we used to offer it in our office. That changed a little bit for us a while back for a variety of reasons. I do still think it is a very worthwhile test to offer, though, especially for people that is, more in their wheelhouse. I think as an audiologist, we are certainly a good first line for noticing cognitive changes in folks. And I think a big part of it too is because we spend so much time with people. We frequently will talk about our patients becoming basically like extensions of our family, because we do spend so much time. I know increasingly with GPs, you don't get a whole lot of time when you go in. You're cranked out pretty darn quick. Their schedules are really packed. And unfortunately, insurance kind of mandates that they be that way in a lot of ways. But we still take a ton of time with patients. I minimally, for an intake, I see people for an hour, sometimes 90 minutes, sometimes 2 hours, depends on what kind of testing we're doing and the extent of things. So I have a lot of opportunity to have really good conversations with folks and see changes that happen because, if you have a good relationship with people, you might be their provider for a huge portion of their life. I mean, you could be somebody's provider for, 20 years, 40 years, whatever, like there's a huge evolution that occurs over the course of their life that we are privy to. And I know, like when it comes to dementia specifically, a lot of times we have our pulse on that sometimes before anybody else has even mentioned it. I've brought it up to patients before, and it's obviously a very sensitive topic. And you want to make sure that you are addressing that in a way that is as sensitive to their feelings on it. A lot of people, there's a lot of stigma, of course, about our changes in our brain and aging, and making sure that you're doing that in a way that doesn't feel insulting, I think is hugely important. And in sharing that information with their physician, I'm sometimes surprised when I do talk to docs about how much they, I don't want to say poo-poo, but I feel like don't always take the concerns that we have, or maybe even that patients have, as seriously as we would like them to. And sometimes patients will tell me that. I'll say, well, did you bring that up to, Dr. So-and-so when you were there? And they'll say, well, I kind of did, but they said, oh, you're fine. You're normal for your age, and just kind of swept it under the rug. So to me, that is super duper frustrating. And I have encouraged them to push for more, maybe, go somewhere else, get a second opinion, because I have a strong belief that you have to advocate for yourself, right? If you don't advocate yourself and push for the care that you need, you might not get it. That's unfortunate. It shouldn't be that way, but sometimes it is.
So Vicky came back with just making sure cognitive view, COG.
Cognitive view. Yep, sorry.
So is that the correct spelling? That
COG. Oh, she got it. Let me look in the chat here and see.
she said COGNIVIEW, like cognitive and view. Is that correct?
You got it.
Okay. All right, good. Okay. Are you close to the end?
I am. Yep. And I can, some of this,
No, you can go
apologize.
ahead and,
I know I've
no,
been a little
we
lengthy.
have till we have the captioner until 11:15, so we can continue till then if need be.
Okay.
But I just wanted to, yeah.
Yeah, no problem. Kind of going back to options, to help folks. I mentioned before oral rehabilitation being a pretty significant tool in our tool belt that I think is pretty underutilized. This is also one that if anybody would like resources on, certainly feel free to reach out to me. But like I said, with or without hearing devices, everybody benefits from oral rehab. I feel like I hear and process better when I go through these. If I do like a few months of going through various training exercises, and it's not a huge time commitment, 15, 20 minutes a day, or, maybe like a month, 2 months, 3 months, it makes a big difference though, in how well I feel like I'm actually understanding and processing. So they're certainly worthwhile. When we are thinking about technology for hearing evolves so quickly. We typically see new releases every 6 months. Generally, there is an appreciable difference in the sound quality, in my opinion. I'd say about every 2 years. There might be, times where that's not exactly the hard and fast, but there certainly are pretty significant improvements in hearing aid technology, at least at that point. This listing here, this is just of the main manufacturers that are, producing hearing aids. These are their current platforms, just in the event that you're wanting to kind of dig into anything a little bit more. The amazing thing with technology now is that there are so many features, as I mentioned, that are standard. Every manufacturer offers rechargeable instruments, and that is a huge, huge benefit to improving accessibility for folks. When you think about how tiny hearing aids are and how tiny the batteries are, that is something that people definitely struggle with or have struggled with in the past. They're not the easiest to change. So being rechargeable is a game changer, and having the rechargeable element be available in any form factor. And when I say form factor, I mean like the look of the hearing aid. So is it a behind the ear? Does it just go in the ear? Maybe it's a large in the ear, maybe it's a small in the ear. There's a huge range of options, but pretty much every option, every size or style of hearing aid can be rechargeable. Bluetooth is also something that's standard at all technology levels. So not all form factors, not every size of hearing aid can accommodate a Bluetooth antenna, but every level of technology. And technology levels are one that definitely are, I think sometimes they're misunderstood. And sometimes people think, well, is there a difference between, a $4,000 hearing aid and a $500 hearing aid? Certainly there is. And the technology differentiators, one of the biggest ones is noise reduction. So when we go up in technology, we have more types of noise reduction and we have more steps of noise reduction available. So what I mean by that is it a speech noise? Is it a transient noise? So a brief loud sound going off. Is it machine sound? So like maybe a blower on like a fan, air conditioning, whatever. Is it wind noise? That's a big one. If you're spending a lot of time outdoors, wind moving over the microphones. And those are certainly things that become much more robust and much more automatic at higher levels of technology. Smartphone apps, every manufacturer has a smartphone app nowadays, so you don't have to purchase a remote control if you would like to be able to have some control over the hearing aids. And smartphone apps are hugely varied in what patients have access to. Sometimes it is just a basic thing like a volume control or maybe some different settings. Sometimes it is very sophisticated, the ability to override the directionality of the hearing aids. The one in the picture here is an example of one where you can say, hey, I want to make my hearing aids forward facing, rear facing, right, left. If I'm forward facing, maybe I want to really narrow the focus so that if I'm in a noisy situation, I can really help to cut down on the noise coming from the sides, coming from behind. A lot of manufacturers offer tinnitus options built into the hearing aids. And this is such a huge benefit for patients that have tinnitus, which typically does go hand in hand with hearing loss. I listed a couple that have really wide array of options, but there's so many different types of therapy that we can integrate with the amplification where a patient does not have to have two different devices. They can do all of it in one. And again, AI, machine learning, that's a big one that manufacturers have really been making good use of. Being able to have the data from lots and lots of different soundscapes, sound environments, being able to take that and provide instructions to the hearing aids to be able to make changes in real time, utilizing sensors on the hearing aids that analyze how the patient is moving, accelerometers. There's so many different elements to hearing aid technology that just make it more streamlined, more sophisticated, and more custom to each patient's individual environments and listening needs. And along with that, a variety of different accessories. So there's a lot of stuff that I have listed on here. One of them I'll just touch on. I'll try to go real quick on this is the one that's in the picture. And that is, it's called a Roger. This one happens to be called a Roger In or IN. And this is a super duper cool device for people, particularly who are working or in more challenging environments. This is a device that lets them take the sound from conversations and it will send it wirelessly into the hearing aids. They can use it as a pointer, so they can literally kind of point it at a person to help bring in that sound. They can have a companion wear this. They can put it on a tabletop and there's multiple microphones. And the microphones have directionality. They have noise reduction built into those different directional beams too. So not only are you being able to pull in speech around a table, but you're getting noise reduction for it as well. You can plug it into a base and it can stream television. You can hook it up to a computer. I mean, just so many cool things that you can do right from that one device. And there's lots and lots of different accessories and devices out there that can be used with or without hearing aids. So I will wrap it at that. I realize, again, I've gone a bit long. I apologize, and I appreciate you guys lending me your time for today. If you have questions, certainly I'm available. If there's anything you want to ask or you want to reach out to me, if there's resources that I can provide for you. Like I said, my goal is to be a good resource and to be able to help people be successful with their hearing journeys, whatever that might look like. So thank you.
Well, and I just want to tell you that for those of you that would see Go, her office is wonderful to deal with, partially because Tyler's so great as well, because he helped set all this up. And what a wonderful person to have as a part of your practice. So I encourage people to get a hold of the doctor's office if they have any follow-up. And as I said, this presentation will be available on our YouTube channel in about a week. And also the docs that the slides I put in the chat earlier. So if folks want to take a look at those are there and you'll have a moment to do that. But Dr. Bogue, I just can't tell you how much I learned and how great this presentation was. I'm stunned with what I didn't know. I'm sure that for many people felt that way. So thank you so much for sharing your knowledge and in such an accessible way.
Thank you.
I very much appreciate it. It doesn't look like anybody else has any questions at the moment. You can leave your slide up there for a minute while I'm telling them so that if they want to get a hold of you, they can get that information. You can also reach out to us and I'll be happy to share the doctor's details with you.
I'll let you know too if anybody is around, just as a real quick. So Friday mornings, we also have a walk-in clinic. So Tyler, who is my husband, we're there on Friday mornings from 9 to noon for specifically this walk-in clinic. It's first come, first serve. We have a sign-in sheet up front. We have Hinckley's if you're local. So, there's a little treat there, but that's a nice option. If anybody ever needed to pop in, you need to get something, you have a question, you want me to look in your ears, there's lots of stuff that we do and just these kind of real quick appointments. So just to know that that exists for patients. We have a lot of people that might just come in for wax removal, but we try to have that as a weekly resource for patients in case you need it.
Wow, that sounds like a great community asset. Thank you so much for that as well. I just want to invite everybody to come back on May the 8th at 10 o'clock for an assistive technology topic. I don't yet have completely what the name of it is, but I think it'll be great. It's being headed up by Disability Rights Michigan. So there will be good content there for folks that want to come back on May the 8th and join us at 10. And thank you again. I very much appreciate all your attendance. And is there another question? Oh, good presentation. Thank you, Doctor. And let's see, we did that one. Thank you and thank you. So lots of thank yous. So it's not just me.
Thank you. I appreciate your guys' time.
All right. Have a great rest of your day, everyone. Bye-bye.
Thank you, guys.